Now start in the name of the Almighty, most merciful and beneficent. This is the answering section of the X-ray chest which were mounted in front of you, 5 X-rays, and I am Professor Sayyid Ali Azhar. Try to answer or to interpret these X-rays, chest skygrams. First was the 45-year-old having the antalgic gait and painful inspiration. All parameters of the X-rays they are fulfilled, and although the thing is that in this X-ray we find that the antalgic gait, he has got antalgic gait. Actually this is wrong. Age was given wrong in that scenario. Now this is about the age of 15 years or 16 years old lady having that antalgic gait and painful inspiration. Now see all the parameters, starting with the requirements and all the things, and the soft tissue shadows and the bony skeleton and all the other parameters. What is the positive finding in this X-ray? Now see, remember, try to count the ribs here. See, there is definitely the hypertensivency are seen in the clavicle. Osteoporotic changes are definitely visible here. Look, this and this and this, no doubt about it. And then this is the spine, which is visible, rather more visible, although it is the PA view. And these are the anterior projections which are not seen very clearly, although some of them are visible. For example, here 1, 2, 3, 4. This is the 5 one, and this is 6 and this is 7. Try to see this X-ray in this fashion, which I am seeing: the upper border, the lower border, upper border, the posterior borders. Now here, posterior borders, you see there is hair gap seen in certain ribs. These are the linear markings, gaps. What is more prominent here is the scapulae, lateral border, medial border, lateral border, medial border, which is visible. And in this inferior angle of the scapulae, there is a linear line which is going up, this one. Now all bones are affected in this fashion, and this is actually, there are pseudo fractures which are present in this X-rays, and we call it the loser zones in our terminology. The loser zones are only present in one condition, and that is sine qua radiological finding. So this is a bony skeletal problem which is seen in this X-ray. Although all the bones are not shown here, those which are shown, the clear-cut loser zones are seen in this X-ray if you see the X-ray properly. It means that is some bony lesions, and the bony lesions are the lesion in which the demineralization is actually are the cause of the bony problem. Now, the terminologies which we use here is for differential diagnosis: the osteoporosis and the adynamic bone disease, and the pain occurs in the bones because of the secondaries in the bones or the ribs. It may be painful, or in cases of the osteomalacia or rickets in the young ages. Where the important point is that the mineral phase of the bone is lacking or reduced, rather the organic matrix, which is not disturbed. This is called osteomalacia. There are many causes of the osteomalacia should be sought out, whether because of the primary osteomalacia or the secondary osteomalacia. Because osteomalacia is associated with osteoporosis means that there is a proportional loss of the organic matters to the mineral matrix. The two terminologies are very, very close to each other. So the only conformity test in the world, although they said that in urine for the hydroxyproline or other amino acid derivatives can be found. And in osteomalacia, you do the alkaline phosphatase, which is highly raised. In osteoporosis, no alkaline phosphatase is raised. And you can confirm it only one, and that is biopsy of the bone. From the sternum you take, or from somewhere you retain, where you find the proportion of the mineral cortex is gone in comparison with the organic cortex. This is the gold standard diagnosis of this. Otherwise, clinically, the patient has been osteoporotic or osteomalacic or Adenic bone disease or secondary in the bone, etc. But so you will do the other parts. The pelvic bones should be visualized to confirm the loser zones, where it is very, very commonly seen places. And loser zone occur because of the blood supply actually is crossing over the bone. Because in the blood vessel there is blood in comparison to the other part, for example here or here, the bone is actually demineralized. So blood column is going on, which differentiate the sites, and it causes the loser zones. It causes the impression of the pseudo fractures, which is not actually fracture. The management is you have to give the vitamin D and other calciums and other derivatives, phosphates. They have tried the bisphosphonates in this condition. They have tried the other drugs which are claimed to be effective in the osteomalacia. The second X-ray was 33-year-old past history of the CABG, now presenting with the laboured breathing. This is the history of the cabbage very recently, and the patient is now presenting with the laboured breathing. Interpreting this is the wiring which is seen, and the bony skeleton is, and the soft tissue cell, etc. all are seen here. Now look this. Of the lung field comparison is concerned, look here, the upper lobe divergence is seen, and the bronchovascular markings are very, very highly in number is going on. Here there is evidence of the Carly B lines, these linear striations. These are the linear striations. And the whole of the chest wall, now these bronchovascular markings are touching the lateral wall. It means the congestive changes are seen. The angle of the left side is obliterated here. It should be very clear. It is flat. The cardiophrenic angle is normal. Here the costophrenic angle is normal, flat, and the cardiophrenic angle is normal. What is I want to show is this thing. Now, this is a very, very a linear type of a structure which has a high density shadow, homogeneous. And this is encysted pleural effusion. If looking to be encysted pleural effusion, there are signs of the one of the stage of the what we call as the pulmonary edema. Evidence is very clear in this case. The right border of the heart, the left border of the heart. If you measure the size of the lower part of the middle mediastinum, the cardiothoracic ratio is increased, there is no doubt, and the apex is going down. It means it is predominant left ventricular failure. Although right here the pulmonary conus is also prominent, but the basic diagnosis is that the left ventricular failure is the commonest complication after CABG, causing the pulmonary edema. The aortic knuckle, because 83 years of age, it is the aortic knuckle very prominent at the clavicle, very near to it. It is what is called as the axial calcification. It is dystrophic calcification. So in this case, the diagnosis is very, very clear, although the cause of the uh, enlarged heart and associated with the pulmonary edema may be it is after the acute myocardial infarction. The CABG has been done and it is a complication. It may become complication of the hypertensive heart disease. The cardiomyopathies can cause this condition. I mean to say that this is a very clear cut. It is the cardiogenic pulmonary edema which is visible. Like the hyla shadows, they are enlarged as well as they are prominent. And the other investigation will do possibly or the ECG or the echocardiography and the routine investigation plus pro-BNP or BNP markers, brain natriuretic peptide. There are 3 or 4 tests available in the different countries which are raised, although it is not the confirmatory diagnosis. The diagnosis of the congestive cardiac failure, the patient is in congestive cardiac failure, is confirmed only by the clinical examination. That is the gold standard, Framingham criteria that is called. Management is general measures, specific measures, reduce preload, reduce the load on the heart by reduction of the oxygen demand by the heart, giving the beta blockers, reducing the preload, giving the diuretics, reducing the afterload, giving the ACE inhibitors or the receptor blockers. So this is the how we manage this case usually. It's a very brief account I have been given. Third one was a 45-year plan for the elective right mastectomy to a symptomless patient referred to you for the medical illness. Right mastectomy. This is a blood shadow. Nothing is seen here. The only positive finding we find in this case is this one. This projection is coming out. It is the homogeneous shadow, very regular margin is seen. Although a cystic type of a projection, base is on the lateral wall, apex on the hair. So it is a differential diagnosis. It is the acute inflammation or the result of the acute inflammation. The university although is given. It may be the pulmonary abscess. Chances are less. And it may be chronic inflammation, that is called tuberculosis of cavity is possible, but at least chances. The fungi can cause this type of problem as well, but least likely. Then further you go in the tumors and the tumor-like state, yes, this is the possibility of the tumor which is arising from here, benign tumor, the bronchial adenoma, or the hematoma which is arising, or any other malformated type of a benign tumor is possible. So it is this, as well as the bronchial carcinoma is concerned, I say the 4% of the cases do occur in this fashion, although not from the lateral wall, from the mid zone or the upper zone, we see in 4% of cases. Allergic conditions and the autoimmune diseases least likely, sarcoidosis least likely, and the parasitic invasion is possible. As a hydatid cyst, what is possible? It is possible as a hydatid cyst, although the calcification or cornification is not seen. So you have to do the lateral view to see what is this, and you do the HRCT to confirm it for the planning. Other routine investigation can be done for the fitness purposes. And after the whole examination, it is found that it is a benign type of a lesion. Then leave this lesion and do the medical fitness, confirm it, and the patient can do the elective right mastectomy. One of the candidates previously was said that it is a secondary within the lung from this side. No, because the thing is that the border is very, very regular. it is homogeneous type of opacity. It is least likely, and there is no secondary effect of this on this side, or the surrounding side. So the management is, of course, there is no management if it is a benign type of opacity. Leave it and see. There is a rule of thumb that how much enlargement occurs in the first 8 weeks and after 2 years. Leave this opacity. If it doubles, it is called doubling sign, then it should be removed as much quicker as possible and do the confirmatory diagnosis by the CT guided biopsy. The two X-rays are shown to you, both presented with acute breathlessness and chest pain. Now here in the first one, hypertranslucency will be there here. You see there is calcification here in the hilar area, and very, very close approximation you will see. To see this X-ray is haziness in this part. The claustrophrenic angle is gone. The irregularity is seen here. Irregularity is seen also here in this non-homogeneous type of obesity which is occupying this place. Both sides. Look, the border of the heart on this side, and this side is turning. The left border is this, and this. And this is actually the part, because the thing is, it is irregular. You see, it is not Ellis's curve. It is not Ellis's curve. Again, in this case, again, this is the curve is coming out from this. It may be mesothelioma. It may be something else, which is a benign tumor or a bronchiolitic carcinoma. Same thing. But look, that this is we call as the thickening of the pleura. Usually seen in this fashion. On the lateral wall or on the basis, it is the tenting of the dome of the diaphragm. On the lateral wall, it may project like this. To confirm it by the other views and HRCT, the sputum for the AFB and DR excluded the other causes which can cause this, the pleural thickening. And if the cause is found, then the specific measure should be done. For example, in tuberculosis, you have to give the ATT for these patients. The condition is painful because of the involvement of the parietal pleura, deep inspiration. Pain will be there, definitely. Breathlessness occurs because of the vital capacity is reduced. The heart size is normal in these cases. So treatment based on this. And the last X-ray was a 32-year-old housewife presented with effort intolerance. And she was a young lady at 32. She was non-alcoholic and she was non-smoker. She was non-offensive. She presented with effort intolerance since about 6 months or 4 months, gradually escalating. To see this X-ray, all parameters are seen, and the breast shadow is seen here, tracheal central, everything. But look, the lower part of the middle meter is seen on the basis. And this is the left border. It is protruding out and is going up. The lower 1/3 represents the left ventricle. The upper 1/3 represents the left atrium. Here the right border, upper 1/3, superior vena cava, inferior 1/3, inferior vena cava, the remaining 2/3 of the right border represent the right atrium. The heart, the cardiac thoracic ratio in this condition is slightly larger, definitely, if you calculate it. What is important to see in this case specifically, because they see the left hilar is actually isodense with the heart shadow, the upper part of the middle mediastinum. Upper middle mediastinum is divided into 4 by arbitrary line. This is line. One line is this and one line is this. This is the ascending part of the aorta. 2 and 3 represent the arch of aorta. Aortic knuckle is there. And fourth one, this protuberant part, is the pulmonary conus, which is highly dense and it is prominent and is enlarged. It represents the hypertension. the pulmonary hypertension. Evidence is also here. You see the hyla are enlarged and prominent, and thick bronchovascular markings are spreading out from it, sprouting effect. Although the lines if they are coming out of the hyla, they are thinning out. Look this. This is called pruning effect. Pruning, P-R-U-N-I-N-G, pruning effect. This is the very important part of the pulmonary arterial type of hypertension. It is not seen in the venous pulmonary hypertension. Especially in suffering from the pulmonary hypertension, because there was no predisposing factor previously, a 32 years old young female presenting like this, mainly it is the cause of the primary pulmonary hypertension, although it is hereditary in some cases. And there are some etiological factors are also been known, HLA, for example. Some groups are there which are prone to develop this condition. So primary pulmonary hypertension, confirmed it by the echocardiography, the other HRCTs should be done, and you will see the pressure inside the pulmonary artery. Catheterization studies can be done and confirm it is primary pulmonary hypertension. Because there is no secondary thing which can do the pulmonary hypertension here, is the primary one. Management is to reduce the pulmonary pressure. It can give the calcium channel antagonist, pentoxifylline, the other things can be given which are available in the country depending. The nitrates, they are effective to reduce it. And sildenafil, they are now using sildenafil, phosphodiesterase 5 inhibitors, are also effective. Busantan, that is a drug which has got the androstenedione receptor blockers, is also been used in this condition. If all the pharmacological interventions have failed, then you go for the transplantation. It may be the lung with the heart, that is the cardiopulmonary transplantation is the answer. Definitely cure can be done, and the survival may be 7 to 8 years after this. Otherwise the patient cannot be survived after 1 or 2 years. Difficult to survive in this condition. So these are the cases which I have discussed. Although more discussion is needed here, because of the lack of the time I cannot discuss beyond this. So repeat it, inshallah ta'ala. We will meet again with the section 9, then about part 9, inshallah. Goodbye, good night, and good luck for your future examinations.